Thank you. Hello, everybody. Thank you. Thank you for silencing in the room. Just if we make a start, and I promise I will go through this presentation as quickly as possible, because you must all be quite hungry by now. And I'm sorry we're running a bit behind time, but with these fascinating talks, it's hard to kind of keep things to time sometimes, so apologies. Right, I think that's most people back in the room. So I'm going to make a start. So, as I said before, I'm Lisa. I'm one of the pouch nurses at St Mark's, and I work with Zara, who's now the consultant nurse in pouch care, and she's currently on secondment with London Procurement. There's myself, I've been in post for about 8 years, and then my colleague Sam, who's also here today, she joined us about 3.5 years ago. So we're getting more and more experienced with what we're helping patients with as we go along. So, I'm just going to discuss what normal pouch function is, when to seek advice when you've got a pouch, types of potential complications with a pouch, and I'm not going to go through them all. Investigations that people might need to undergo if they start to have symptoms of a potential complication, and then treatments of management. I could talk about this for hours, so you'll be reassured I'm not going to. And what the idea of this presentation is to not scare people, because I understand that some people are sitting here potentially having a pouch, but part of having a pouch is sort of having realistic expectations of what a pouch could be like, and to go into it with eyes wide open, really. So that's partly why we talk about complications, not to petrify people out of having a pouch, but just possibilities. And for those of you who are sitting here with a pouch, just sometimes you might have a few days where you're feeling a bit rough, and it might just start you thinking, oh, well, is this getting better? Is it getting worse? And what potentially could the problem be? So just to show a bit of anatomy here. So we've been talking about this J pouch. This is the ileum folded back into a J shape. This is where the pouch and the rectal cuff, which is usually about 1.5 to 2 centimetres, is anastomosed onto the pouch. You've got your sphincters here, so your bottom hole essentially, keeping everything in, and then your dentate line, which is your sensation line that your brain is receiving signals from that you need to go to the toilet. Expectations are huge when having a pouch, and I think it's really key for those that are considering having pouch surgery that they... Hello?
Sorry to interrupt.
That's right.
My son, he needs to hear this. He's just gone to the loo.
Right. Okay. Well, I can always send you the presentation, which is going to go on the website, or...
That's why he's come actually, just to hear this.
Right. Okay. And I can always go through it with him again, or is that just because I'm conscious of the time? Sorry. So, just considering when you have a pouch, what your function could be like, how it's going to fit into your lifestyle, what routine you'll be able to have, the diet that you might be able to tolerate with the pouch, work, how that's going to affect your working life, sports, are you a really sporty person? Do you want to return to sport after you've had pouch surgery? Sexual function, which Sam, my colleague, is going to talk about this afternoon, along with fertility and fecundity, pregnancy, and whether you'll be able to travel with your pouch, which is obviously the hope that you will be able to. So there's no really normal with a pouch. It varies hugely from person to person, but we quote on average that someone will need to empty their pouch of a porridge-like consistency 4 to 6 times in 24 hours, and 1, if not more, of those may be at night. People with a pouch should be able to hold on for at least an hour, and this is sort of once everything's settled down. They shouldn't expect any fecal leakage or seepage in the day, and if they get any, it may be at night. And as I've said, it's a very individual thing. When patients have had their stomas closed, so the initial stages, and this can happen over a few weeks post-ileostomy closure, it's very normal for people to have what we call perianal soreness, or what patients tend to call butt burn, anal itch or burning, which is kind of all part of the same thing, nocturnal, so nighttime seepage, say in the night or the day, frequency, increased frequency, it won't settle into a pattern straight away, maybe going backwards and forwards to the toilet with ineffective emptying, so the whole, oh, I've finished, I'll wash my hands, leave the bathroom, and then 5 minutes later be back. That's very normal. And also feeling pretty exhausted with the whole process. 1, people are recovering from having had their stoma closed, so being in hospital again for a few days, and 2, just the whole new routine of getting used to a pouch, which is a big deal, really. So, if I just, did it move? No. All right, it's doing funny things. So, if symptoms are such as these have been going on for a few days, they're not getting any better and actually gradually getting worse, then this is a good time to kind of call a healthcare professional for advice. So if someone has increased pouch frequency, urgency, bleeding, abdominal pain, and this is sort of persistent abdominal pain over a number of days, a fever and particularly night sweats, lethargy, just generally feeling a bit rubbish, bloating, feeling that they're backwards and forwards to the toilet and they're not able to empty properly, possibly feeling a bit sicky and possibly vomiting, incontinence, leakage, and then possible symptoms of fistulae. So any discharge from the back passage or the vagina that's not normal for them. When we talk about complications with pouches, we talk about inflammatory and non-inflammatory. And within the non-inflammatory, there's two groups within those. Inflammatory, and I'm not going to go through all these. We have pouchitis, which I'm sure you've all heard about lots. Cuffitis, which can sometimes be because unfortunately patients have had too much rectum left in, which we see a fair amount of. Something called pre-pouch ileitis, which is inflammation above the pouch. Crohn's disease, which we don't see so much of these days. There are some people who had their pouches a long time ago for what was thought to be ulcerative colitis at the time, and then years later it's transpired it was actually Crohn's disease. And then fistulae, so openings that shouldn't be where they are. Non-inflammatory, I'm not going to go through all these either, but basically some things that have been caused from the surgery. So things like a leak, the surgeons have talked about pelvic sepsis from a leak at the join where it's been stapled together. And then some things like irritable pouch syndrome. So if someone's known to have irritable bowel syndrome prior to being diagnosed with ulcerative colitis or polyposis, it doesn't then mean if they have surgery then they're not going to have an irritable bowel. So sometimes, unfortunately, people go from having an irritable bowel to ulcerative colitis, and then they've still got irritable bowel. So they will have what we call an irritable pouch that gives that abdominal pain, bloating, and it can be very difficult to manage. And then this ineffective emptying of the pouch, which can be for a number of reasons. Investigations that people might talk about, so potentially examining the abdomen when people come into clinic. One that no one is a big fan of, but the finger is a key sort of monitoring device really. So be warned, those of you who haven't yet got a pouch and those that have got one, if they have any troubles will know, coming to clinic usually means a finger up the bottom, unfortunately, just to check if there's anything going on with that join. Sometimes in clinic, that's a bit old school now, we do rigid scopes. Just to have a look and see if we can see anything obvious in the pouch. And if that doesn't work very well, then we send people to endoscopy for more conclusive flexible pouchoscopies, where we can take biopsies and rule out any inflammatory problems. And we can also, or the more experienced gastroenterologists can use endoscopy equipment to balloon dilate any narrowings within the pouch. And then bloods. I know I talked last year about routine follow-up and what bloods people with pouches need. So we recommend people have their bloods done every year, whether they're well or not, when they've got pouch. Other investigations, some of you may have had pouchograms, defecating pouchograms, which I'll just run through very briefly, stool samples that we can send off to the laboratory, CT scans. If anyone's got incontinence problems, they might be sent off for something called anorectal physiology, so just to see what their sphincters are doing. And commonly, if women have had children naturally, we will send them off to anorectal physiology to check their sphincter function before a pouch is kind of committed to. Because what you don't want is a pouch with poor sphincter control. Pouchitis, and one of our research fellows is coming this afternoon to just talk about his work with pouchitis. But pouchitis is an inflammatory response to changes within the pouch. We don't really know the cause of it. We think it's caused by changes in the intraluminal bacteria with the pouch. And as Professor Nichols has said, there's a huge increase in bacteria in any form of reservoir compared with the small bowel flowing into the colon or the small bowel contents going into the ileostomy appliance. We know that up to 50% of patients, particularly with an ulcerative colitis history, will experience pouchitis at some time, but we're not yet clever enough to predict which of those 50% will have pouchitis. Possible causes, so there's multiple reasons that we think it happens: bacteria, immunological factors, excessive bile salt production, and we always advise patients who are known to have something called primary sclerosing cholangitis, which is a condition of the liver that sometimes comes hand in hand with inflammatory bowel disease, that those patients we know are at higher risk of developing pouchitis. So that's key in giving them the information prior to considering having a pouch, because they could end up with pouchitis. Common symptoms of pouchitis: frequency, loose stool that's not responding over a few days to changes in diet, so carbohydrates to try and thicken things up, or loperamide, you're taking normal doses of loperamide, nothing's happening. Abdominal pain or cramping that's sort of continuing, feeling generally under the weather, possible fever, bleeding, symptoms not getting any better, and so things just are not going in the right direction. With pouchitis, a lot of people say, I think I've got pouchitis, but there's 3 ways of knowing that, which can be a bit long-winded, but assessing what the person's symptoms are, sending them down to endoscopy for a scope to see what the endoscopist actually sees with the camera, and then taking biopsy results. And all 3 bits of information then establish whether someone's got true pouchitis. Obviously, that can sometimes take quite a while to organise, so sometimes we end up treating people for suspected pouchitis rather than leaving to suffer. Pouchoscopy, you're probably all familiar with this sort of setup, because it's obviously an endoscopy where people have scopes with their colitis. There's 3 classifications of pouchitis. There's simple pouchitis, with 1 episode a year that tend to respond to a short course of antibiotics. And then there's complex pouchitis, 2 classifications, where people are having more than 3 episodes a year, which in my mind, I don't think 3 is that many to call it chronic, actually, but that's the way it's all grouped. We have I think it's probably about 18 months, 2 years old now, a protocol that we use. We had 3 separate ones, and John Siegel, who's talking this afternoon, has put it all together. So when we're managing patients in our telephone clinic, we're working our way through a protocol, basically. Most common treatment with antibiotics for suspected or true pouchitis is a 2-week course of ciprofloxacin, 500 milligrams twice a day. And if they have a rapid relapse, then they would take that for a 28-day course alongside metronidazole, which can make people a bit nauseous. So it's not a commonly well-tolerated drug. The protocol says 3 times a day from the evidence that's out there. If people are struggling, then we go on to twice a day. And then if they're really not getting it at all, then we have to revert to something else if they're not tolerating it. Cuffitis, so where the cuff, that's the rectal tissue, becomes inflamed, can give similar symptoms. Frequency, there's more likely to be urgency with cuff problems. Bleeding is more common than in pouchitis, and then people describe feeling that they've got an egg or a golf ball continually up their bottom, and some people actually feel like it's really quite difficult to sit down comfortably, and with that comes pain. We give suppositories for a 6-week course, so the same sort of suppositories you would have had to treat any proctitis or rectal disease in the rectal stump. And if the rectal cuff is found to be too long, and we've had patients come along sort of after 20 years of having a pouch, and they've got 15 centimetres of rectum, essentially their whole rectum still attached to their pouch, and somehow they've not had problems for 20 years, and then it's all flared up. So they've had to undergo quite big surgery to remove the rectum that was the plan for the operation in the first place. Symptoms of ineffective emptying. So some people experience this for short periods, and then if it's a prolonged problem, then it needs to be investigated. So multiple visits to the toilet in a short space of time. Knowing that you're not emptying effectively. Straining, you shouldn't technically need to strain with a pouch. It's never going to be more than sort of porridgey, pasty-like consistency. And straining comes from the sort of learned behaviour from being a child when you're toilet trained to strain, but you shouldn't really be straining with a pouch. Finding it's just as difficult to empty with loose stool as it is porridgey pasty consistency. Experiencing leakage, if that's not normal, that can sometimes be a problem or indicate a problem. And it could be that there's a narrowing of the pouch anal anastomosis, which is where the join is. Strictures you get in commonly at the bottom end of the pouch where the anastomosis is stapled, but you can get them in the mid pouch and also in the upper pouch. And we're still not quite clear why that is. The mid and upper pouch is more due to inflammatory problems. The bottom end is more just a sort of a circular scar. If scar tissue builds up, that can narrow down over time, or pelvic sepsis where someone's had a leak. Hagar dilators, I don't know if anyone uses a Hagar dilator. I've got some up here if anyone's interested in just seeing what one is. And we commonly get called to the theatre admissions unit when patients have come in because they've got a narrowing of their bottom end. There's no way if it's narrowed down they're going to be able to stretch it up themselves. They need to have a day case trip to theatre and it's stretched up under anaesthetic, and then we come along with a nice looking instrument and advise them that they will need to use this for about 3 days a week. And it sounds horrendous, but people tend to tolerate it quite well, and it means that they don't come back for other theatre visits and that they continually are able to empty their pouch effectively. It sort of becomes part of their routine. Pouch emptying, we talk a lot about when patients have got new pouches about how to sit correctly on the toilet, and everyone should be sitting on the toilet like this, whether they've got a rectum or a pouch, because we're not really designed for toilets. Western toilets kind of get in the way. We're supposed to be more of a sort of semi-squatting position. So a lot of people with pouches would actually find it to squat in a toilet over the, a hole in the ground. And position-wise, that's actually much better than getting a toilet in the way, if you like. So emptying, if people are having trouble, sitting on the toilet in the correct position is key. Sometimes if people are having trouble, then they have what's called a defecating pouchogram to assess whether the pouch is emptying. And as we've had discussions here over the years, some people need to use what we call a Medina catheter, which is a plastic tube. You see, again, people can have a look if they want to, that can work wonders in improving people's quality of life. If they've got a functional problem and the pouch isn't emptying as it should do, and it's deemed to be functional as opposed to a stricture, then Medina catheters can work really, really well. They take a bit of getting used to, but they have improved quality of life no end for some patients. Biofeedback is a sort of treatment that is in a lot of places in the country now, and we have really quite a big team at St Mark's, and patients would be signed up for sort of a 6-visit course of treatment. And I won't go into detail, but it's basically retraining the brain and the pouch and how it all works, and going through various medications and things. And there's something called a Renew insert that I think we may have discussed here before. And again, there's some of those here. So for people who may have any leakage or seepage, particularly at night, there's these silicone sort of plugs that are on the right there. You can insert up into the anal canal, and that prevents any leakage. And that can work wonders as well. Much better than the old style anal plug that was a lot more solid and people found very uncomfortable. And this thing on the left is called a Cufora, and that's like a mini irrigation pump. So if people don't get on with using a Medina catheter, which goes up into the pouch, then this just sits at the bottom end. And it sounds bizarre, but you squirt water up and it kind of flushes out the pouch. And again, that's a way of helping people if they have any problems. So, people undergoing pouch surgery really need to be fully informed before they kind of sign on the dotted line. And that's one reason for the Red Line Group being very much here in this current climate, is to talk to people and see what their experiences are all about, both people with good pouches and less good pouches, to get kind of a balanced view of what having a pouch is all about. Pouches can have complications, but as both surgeons have alluded to, they can commonly be fixed. It's not all kind of doom and gloom with a pouch, and I know many people who are out there having a brilliant life with a pouch. And I would always say to seek advice from a healthcare professional. So some GPs, if they have come across someone with a pouch before, will be very helpful and they know what they're talking about, and some GPs will struggle to understand the concept of a pouch. We have a lot of patients who phone up and said, I spent 5 minutes of my 10 minutes explaining what I've had done, and then say, right, well, it's time to examine you, and they hop up on the couch and they're like, well, where's your stoma bag gone? So it's just, I think from what we'd like to do from a pouch team point of view is kind of really get education out there, particularly to GPs all over the country, to help improve the support that people with pouches have. But it's a time issue really, but that's something on our list is how we'd like to educate the country generally about pouches. And I think that's it. Has anybody got any questions at all? I meant to say that our contact details are at the back there. if anybody is interested. And then there's also some supplies of barrier creams. I did order a lot more, but unfortunately they didn't come in time. The Ilex paste is supposed to be quite good for people who've got sore skin, but the company have asked that if people are taking those away and they feel that the sample works and they feel they would benefit from it, then they can... it's probably easier because that Oakmed supply, they've bought the patent over from America. They would be it'd be easier to sign up with the delivery company, so the Ilex can kind of be delivered to the door. It would need to be prescribed, but the delivery company is the quicker way to get hold of it rather than going through a pharmacy, because they are the producers of that cream. If anyone's interested in trying some Ilex, does anyone have any questions? Have I all petrified you, Lucille? Qfora. They are made by a company, and it's probably best to speak to us because it's not something you sort of need a healthcare professional to show you how to use it, basically. And people coming through biofeedback would have access to a Qfora. Okay. Hello. What sort of travelling? Sort of in hotels or roughing it, or?
No, moving to a new house every 6 months.
Right. Okay. So fairly settled, not like camping for 10 months or anything. No. So that would be absolutely fun. Some pouches, well, I would probably say all pouches, don't do very well on stress and change of routine. That's the only thing I would say. But if you're going to be spending a period of time in a certain place, it wouldn't take long to kind of adapt and settle in. So perhaps be prepared for things to just change slightly when you're settling in, and then hopefully it will get better once you kind of know where you are and what you're doing. But no, pouches don't tend to stop people doing anything, essentially. It's just kind of allowing people to have time for everything to settle down. We spend a lot of time counselling patients for pouch surgery, and we always explain that when the stoma is closed, so either after the second or the third operation, depending on the chain of events, that is just the beginning. It's not, oh, I've had 2-3 surgeries, yeah, hey, that's it, finished. It's at the point that the stoma is closed is when people need the most support, we find, and also it's just the beginning, and it can take sort of 6 to 12 months for function. Not to be terrible for 6 months, but for really the person who's got the pouch to really understand what their pouch is all about. I think having a stoma is hugely life-changing for many, many reasons, and commonly people haven't had much time to prepare because it's acute surgery, etc. But changing a stoma bag is a very practical thing, and once you've learned how to change a stoma bag, you sort of got your head around the practical, and then it's dealing with managing the psychological side of things. With having a pouch, it takes a lot longer than learning how to change a stoma bag. Does that make sense? It takes a lot of adapting to. And also I think people have very different experiences. So with their pouches, we could have 10 patients who've gone through the same surgery at the same time. They all have very, very individual experiences. So it's sort of kind of being willing to sort of understand that really, and just almost sounds daft, but going with the flow and taking one day at a time, particularly in the early days, because it varies hugely as to people's experiences. But it's just, time is a huge factor with all of these things, just allowing everything to settle down. Okay. Right, I think are we ready for lunch, do you know? Yes, we're ready for lunch. Well, hey. Right, so lunch. Thank you. So lunch is back down to the right, where we were.